today I'll be talking about pre-eclampsia and aneuploidy screening, but I thought I should update this group first because you guys are the champions or the leaders in fetal medicine in this country. So you should be ahead in terms of your knowledge. We do not want to find things with everyone else. So this is why I thought, let me have this morning meeting. Today we are still going to have the evening meeting. I know some of you may not be able to attend the evening meeting, maybe because of the network issues where you stay and so forth and so forth. And sometimes the power issues, I still understand there's still load shedding going on in some areas. Right. So this is an update on pre-eclampsia and aneuploidy screening. Those who work with us, I think you have seen that we have been trying to screen for pre-eclampsia and aneuploidy. And of late, there are quite a number of developments that have happened in this country in the last few months that have necessitated us to talk about this topic. One of the major developments is that we now have a local laboratory which is now performing PAPE and free BTCG, and also doing S-FLIT1 and PLGF. I know some of you begin to ask me and say, what is PLGF and S-FLIT1? I'll explain this. So these new developments means our screening algorithms has been improved. Before we were telling patients that you can't do this, you can't do this, or it is to be sent to South Africa, we have to wait for a week to just get results. But at the moment, we are now in a position where we can get results within 24 hours. At most 48 hours, we can get the results of the combined test or results of the screening for pre-eclampsia. Admin, do you mind meeting somebody with an open mic? Just say, can they meet them? I think sister, okay, sister, I've muted it. Right. Right. So let's begin. Oops. What's happening here? Okay, let me see. How can I begin? Right. So this is the evolution of the screening for Down syndrome. The screening for Down syndrome started in the 1970s. This is where people were using the woman's age to say if the woman is above the age of 35, they had to be screened for Downs. Unfortunately, there are people who are still doing this practice, which is quite belongs to the 1970s. But we now know that babies Downs can be born even in a woman who is 19 years. So people moved and they began to do the serum alpha fetoprotein in the 1980s. Then the triple test was being done because then, this whole evolution of the Down syndrome screening started in England, whereby then the Minister of Health in England, Arthur Greenwood, came up with an antenatal care protocol for pregnant women because pregnant women had protested that they wanted to be looked after better. So he came up with a protocol whereby women were supposed to start presenting at 16 weeks. So there was no option for second trimester because nobody would pitch up before 16 weeks to the health workers. So most of this screening which I mentioned was happening in the second trimester. When we are saying maternal age was being used as a screening, that means women above the age of 35 would go straight to have an amniocentesis. The moment you get 35 and try to have a baby, they would prick you and get the fluid and check if there's Down or not. Then if your serum alpha fetoprotein was above abnormal, you are going to get a need to prick. Then the triple test was to try and improve the detection rate because these two tests, this one had basis a detection improved about 35%. This one improved it probably to around 50% there. But this one, when it came in, the triple test can get up to 60%, 65, 66%, while the quadruple test may probably approach around 80. So it was a way of trying to improve, because there were still missing babies with Down syndrome despite all the screening tests. Then in the 90s, that's when the knockout translucency started, when Professor Aneuploidy discovered that the knockout translucency can actually be used to screen for Downs. The knockout translucency on its own, again, a detection rate of around 66%. But the main change that happened between the triple test, the AFP, and the knockout translucency is that women were now having the opportunity to be screened early in first trimester. But the issue is women were always been told that you shouldn't come until you are 16 weeks. So Professor Cladious had to advocate for what you call the turning of the pyramid of care. When he wrote in his paper here, that you should turn the pyramid of care so that women can come at 12 weeks, so that they can benefit from being screened by knockout translucency. This started happening. We started speaking about the turning of the pyramid of care in the 90s, but it started happening in the 2000s. Otherwise, prior to that, most women would naturally present in second trimester, just exactly the same way that most of our people are still behaving at the moment. In other words, most of our people are still in the 80s in terms of health-seeking behavior, but in developed nations, most women have moved, and they are now more in the 90s and the 2000s, where they present in first trimester so that they can benefit from having a knockout translucency done and having a more accurate test and having an early diagnosis done to allow for early decision making. So this is what we believe in fetal medicine, that women should not book at 16 weeks. Women should actually book around 12 weeks or before 12 weeks if possible. That is modern obstetric care. It's not just fetal medicine, it is modern obstetric care. This is what we advocate for. So in the 2000s, that's when the combined test started. What we are doing now in most of our units is called the combined test, where we do the scan, the knockout translucency and the other markers, then we ask the woman to go for the blood test. That is called the combined test. Then in the 2010s, that's when the fetal cell-free DNA test came in, the NIPT, which is probably the modern test. But it does not replace the need for a scan between 11 to 12, 13 weeks, because the scan still has some benefits. So in other words, when the pyramid of care is turned, women no longer come for the obvious. Normally, women would present at the 11 to 13 weeks to just have these things done on them, and normally to just be screened for anemia, for common things, HIV. But we are saying now, with the advent of fetal medicine and the widespread use of ultrasound in obstetrics, the first trimester appointment now entails screening for major fetal defects, screening for Down syndrome, Edwards and Patau, screening for pre-eclampsia, fetal growth retardation, and even preterm birth. This is the new modern care in obstetrics and even in midwifery, because we are saying we should screen beyond the common thing that we used to screen. We are very aware that even though the pyramid of care is turned for others, it has not turned for us. As you can see here, that if you look at our national data, this is the percentage of women who book at least before 16 weeks. This is what we call early ANC booking in our country. Say if your woman books below 16 weeks, I think if we zoom it down and say if they book before 13 weeks plus 6 days, it might even be less than 20%. But this is where we are. So that means more than 70% of our women still present in second trimester. So we may still be stuck in the 1980s in trying to implement modern healthcare. However, the encouraging thing is that 80% or slightly above 80% of our women actually do attend ANC care. So there is still room to intervene in quite a big proportion of our women in terms of screening. So to just remind you, I think most of you by now you know what aneuploidy screening is, the combined test. So the combined test, we use the woman's age when screening for Downs. And we also use the knockout translucency. If we use the additional markers, we check the nasal bone, the ductus venosus, and also the trachea with regurgitation. If we input additional markers, you can just put nasal bone and NT in the screening algorithm. If it works, of course, it will affect your detection rate. Then you also ask them to go to the lab to have a PAPE and a free beta HCG measured. Free beta HCG, the change in babies with Down syndrome. This is beyond this talk. You can find a detail of this talk in our YouTube channel in terms of the behaviors of these two in babies with Downs. And of course, we also know that the knockout translucency is measured against the CRL in terms of its comparison, whether it is normal or abnormal. And all these values are calculated to multiples of median. Both the knockout translucency, the PAPE, and the free beta HCG, when we are working out the risk for Down syndrome, we use what we call multiples of median. What is a multiple of median? Multiple of median, we are saying how many times does the measured value go into the population median. The median is the median number that you are going to get. Let's say you measure 100 people. The number in the middle of that measurement is the median. So we are saying if we measure the sample today, how many times does it go into that population median? And this is the comparison of the screening methods that you see there. You can see that knockout translucency on its own will probably pick up 66% of babies down. And if we just do PAPE and free beta HCG and you don't do anything else, you will pick up 60. That means you miss 40. If you do the combined test, just the NT, beta, PAPE and free beta HCG, and of course the woman's age, do not forget that. It's there in the combined test. We are going to pick about 85% of the Down syndrome. These are the false positive rates. Take note of the false positive rate. When you're saying false positive rate, what are the consequences of the false positive rate? Before the era of the NIPT, a false positive rate will mean more women are going to have the amniocentesis than necessary. We're going to be doing more unnecessary amniocentesis because most of the women who have done amniocentesis will turn out not to have the suggested syndrome. Then if we use the secondary markers like we do in the FMU, where we measure check the nasal bone, whether it's present or absent, where we do the ductus venosus, Doppler, and the trachea with regurgitation, we are going to achieve a detection rate of around 92%. You see that there is an improvement in the detection rate with the more markers included in the screening algorithm. Then if we just do the triple test in the second trimester, our detection rate is about 69%. If we do the quadruple test, it approaches about 80%. However, NIPT is way superior in terms of screening for Down syndrome in whatever trimester. The first 3 here we mentioned, these are first trimester screening tools, and these are second trimester screening tools. While NIPT covers all the gestations, it doesn't matter. You can even do it 37 weeks if need be, but the clinical relevance of it then is probably the issue. They say you're testing at 37 weeks. What will you be aiming to achieve at 37? Because then probably by the time you get the result, maybe the woman will have delivered. Or the time you want to do an amnio, the woman would have delivered. So, yeah, but just know that you can do it in all trimesters. As long as you still have enough time to make the decision, NIPT can be done even at 32 weeks. You can still do it if the woman wants to have it done for one reason or another, or if there's a clinical indication. Now, so the combined test, because we now have a local laboratory, this is how the results will come up. When you send them to the medical, or to the local laboratory, which is MedCity, the cost is not much less than what it used to be. It used to be $75 US, the way we were sending samples outside the country. But now it costs about $42 to $45, depending on where it is done, because there may also be a blood draw charge. But it costs as little as $42 and as maximum as $45 to have the PAPE and free BTSCG done, which is a significant cost cut. I think it is now equivalent to the price of FBC and UNE, probably almost there, which makes sense. So if we are to do the combined test using the local laboratory, this is how the results will come up. So you can see that this was the value of the PAPE, and these are the multiples of median here, and this is the free BTSCG, and these are the multiples of median. These are the absolute numbers in terms of the values. And this was the NT for this particular patient, and this was the multiples of median. On this side here, you can see we have put in the reference ranges. We ask these ranges to be inputted so that we give guidance as to everyone who is going to read the results, so that they know when there is an abnormality, other abnormalities that will be picked up by these tests. While these tests are screening for Downs, they are also screening for other adverse pregnancy outcomes. Like which ones? Like fetal growth restriction, pre-eclampsia, preterm birth. PAPE and free BTSCG also screens for those defects. You could have a result where everything is normal here, where everything is normal. If everything is normal in terms of the Downs, like in this case, you can see these are the risks for Downs. These are the background risk. Before we have inputted all this information, these are the woman's age-related risk, 1 in 300 and 1 in 300, which is a risk according to a cutoff of 1 in 100. Then the adjusted risk is 1 in 559. So you can see that this is low risk. And then for trisomy 18 and 13, this was 200, almost what, 2 million something, less than 1 in 100. So in this case, this will be a low risk for trisomy 21 and trisomy 18 and 13, because you use a risk cutoff of 1 in 100. Why we use a risk of cutoff in 1 in 100? Of course, we've explained it in our prenatal diagnostic talk, which is available on the YouTube. For the sake of time, you can reference there why we ended up opting for a risk cutoff of 1 in 100. Because if you read books, you may find out some countries use 1 in 300, some will use 1 in 250, but we decided that we are going to be using 1 in 100 as our cutoff. Then, yes, the woman is low risk for trisomy 13, trisomy 18, trisomy 21. However, you can see that the norm for the BTSCG is above the reference range we put there. It should not be more than 2 multiples of median. I'll explain why shortly. So when we are reading that result, when we are doing when we interpret the result, this is how we should take it. When you see women at 11 to 30 mgs, as a first line, women should offer them the combined test. But for women who can afford, there is no harm in offering them the NIPT when they come to the 11 to 30 mg scan. The NIPT costs between 500 and 600, depending on what we take. So a woman who can afford, they can be told that there's an option to do NIPT in first trimester. But the preferred test is combined test. Well, it costs $45 in addition of the scanning. They are scanning in the public sector. Probably they only suffer the $45 cost. Of course, in the private sector, it costs around 200 something, including the scan. Actually, 100, yeah, 200 or 100 something, depending on where they are scanned. It may cost them 100 something or 200 something, including the scan, the total cost of the screening. So if we do the combined test, if the risk is high risk, greater than 1 in 100, instead of going straight to the amniocentesis, we should offer them NIPT. Why are we offering NIPT? Because we recognize that the false positive rate for a combined test is about 5%. While that of NIPT is 0.09, it's actually quoted as 0.03 in latest studies. So that means it is very low, so that it may allow us to screen some of the false positives here in women who want to avoid they need to test. But in women who don't want to avoid, let's say the risk is so high that it's 1 in 2 or 1 in 5. In those kind of scenarios, it is better we go straight for the amniocentesis. But just know that a high risk result from the combined test doesn't mean that automatically we have to go for the NIP, for the amniocentesis. We can still go for the NIPT. Then if the risk is intermediate, using the local combined test, we have agreed that it is better. That is between 1 in 100 to 1 in 500. These women should be offered NIPT to just make sure that we screen out some of the conditions, considering that the test doesn't have a 100% detection rate. So we always say they should benefit from NIPT, these women who are in the intermediate risk. If the risk is high, they proceed to the amniocentesis. If the risk is low, we leave the women alone. Then if we do NIPT, then the NIPT will answer itself. If the risk is high, they go straight for the amniocentesis. If it is low, then we leave the woman alone. Then for the combined test, if the risk is low, very low, less than 1 in 500, then we'll leave the woman alone. Then what about in second trimester? For the late bookers, as you are aware that 80% of our women, close to 80%, are more likely to come in the second trimester, more so in the public settings. What do? We have 3 options for these women. We can offer them a detailed anomaly scan and look for soft markers. If we do not find any soft markers and we don't find any defects, we can leave these women alone and reassure them that their chance is less than 1 in 200. If they are happy to take that chance, we leave them alone. However, if we find out that there are soft markers in the second trimester, we go for the NIPT. If there are major defects, of course, there's no need to go for the NIPT. We go straight for the amniocentesis. So if there are major defects, you don't have to do NIPT. You want a diagnostic test. If there are soft markers, 1 or 2 soft markers, you can try NIPT first. If it is high risk, then you go for amniocentesis. I think I'm going to put on the arrow here. Then if the woman chooses triple test, let's say you're in a situation where you cannot get a scan that is as detailed as it should be, where you know that maybe you've sent the woman for a scan where the competency for doing a detailed fetal anomaly scan is not there, where the competence to look for all the soft markers for Down syndrome is not there, then it is better to offer these women triple tests or quadruple tests. If the risk is high, we go straight to NIPT and if the risk from NIPT is high, then we go to amniocentesis. They can alternatively be given the option to do NIPT straight away. If they choose NIPT, then the same applies. If the risk is high, then they go for amniocentesis. So for late bookers, when they come to us, these are their options. If we are able to do the detailed fetal anomaly scan and soft markers, there's no room for triple tests because their detection is actually the same. If not, the scan performs slightly better than the triple or the quadruple test anyway in second trimester. But if they want to do NIPT in terms of ruling out trisomy 21, it is the best test. It may not be the best test at ruling out trisomy 18 and 13, to be honest, but for trisomy 21, it is the best compared to the detailed anomaly scan and the soft markers. So please take note of this. And the handling of the result. Let's assume a scenario. I don't think it's my mic which is making this noise. Let's find out what's going on here. There is some noise coming through. This is Zambuko. I'm going to mute it for now. Excellent. Right. So let's go back to the presentation. Right. Let's assume a scenario whereby you have done the combined test. The risk is low for trisomy 21, it's low for trisomy 18, and it's low for trisomy 13. And now and the knockout translucence above 2 multiples of median. what do? If you are working outside a center where there's no fetal medicine, of course, you refer to fetal medicine. But for us in the fetal medicine unit, what are we going to do? We may consider offering this woman NIPT. However, the desired thing to do would be to do an amniocentesis. Then we also do toe screen, to do a detailed anomaly scan, and offer this woman fetal echocardiography at as early as 16 weeks. Why are we doing this? This information comes from studies that were done on babies who had abnormal nuclear translucency to say their outcome is not good. If you go through the 11 to 13 week scan, the FMF 11 to 13 week scan booklet, you find out that for babies who are euploidy from even having done amniocentesis and they have an abnormal nuclear, 15% of them, they don't live. They have a complication, they have intrauterine fetal demise. Only 15% for those with the nuclear translucency above 6.5 millimeters will end up being born. But the figures are a little bit higher for babies who have a nuclear translucency of just above 3.5 millimeters. Normally, you may find 25% of those babies do not get born. They have one complication or another. And we also have cardiac defects. They are quite common, or other defects. They coexist in babies who otherwise have a normal we have a normal karyotype result. When we are doing amniocentesis for these babies, it is not just the conventional karyotype we want. We also want to do chromosome microarray to them, because karyotype will not pick up deletions and duplication that are less than 5 megabase space. So we need to do a test that zooms in and pick up defects that are as small as 5 kilobase pair, which the chromosome microarray can do. You can pick up deletions and duplication that are (21, 18, 13). We need to assess these babies and offer them the following care plan. Oops, okay. What about in cases where the PAPA is less than 0.5 multiples of median? PAPA, if you read it, there are a number of papers, but I've just put some few of them here. If you read these papers, you find out that if the PAPA is less than 0.5 multiples of median, these babies are susceptible to growth disorders. They are also susceptible to issues like preterm birth. Hence, all babies who turn out to have a low PAPA, we need screen for Downs. Even if they are low risk for Downs, for Edwards and Patel, we need to treat them as babies at risk of fetal growth disorders and babies at risk of preterm birth. Hence, we may want to give them aspirin, then we schedule growth surveillance, and we ask the mother to monitor the blood pressure and also to put them on preterm surveillance. Then for those with the beta HCG above 2 multiples of median, some say it doesn't cause anything. But because it's not very clear in the literature where we are, some papers like the one I quoted, they support that if the beta HCG is high, there is an association with adverse fetal outcome that may include preterm birth and also fetal growth restriction. All those defects do, and also something like diabetes, because we are saying the placenta is big. We have a lot of beta HCG if you are having a big placenta. So having a big placenta is not a good thing as well. So what we do with these women, what we've been doing for them is that we do a detailed scan. We look at the placenta. We make sure we also rule out partial mole, because a partial mole may give you elevated free beta HCG. And we schedule them for growth surveillance, and we ask the mothers to monitor their blood pressures. So in terms of screening for aneuploidy, this is the update which I wanted you to know. That we can now do the screening for aneuploidy, the complete screening, including the ordering of PAPA free beta HCG, and we can get results within 24 to 48 hours. And Medicity are doing this test, a local laboratory, which is a great improvement. So the results will come as displayed, and we should all be able to read these results. The results are not just for doctors. Everyone who works in fetal medicine should know how to read the aneuploidy screening results. It is not just this section you are worried about. You want to look at this section in addition, because this section tell us valuable information about the woman's risk in the pregnancy. Pre-eclampsia, I think I'm going to probably skip this page, but we all know that pre-eclampsia is a global burden, and it is responsible for the maternal mortality figures we have in most parts of the world, which are very high. That is pre-eclampsia. Our national guidelines advocates for risk profiling of pregnant women, so that in this guideline by the Ministry of Health, one of the opening statements here is that assess and grade the pregnancy into either high risk or low risk at booking. This is very important. So risk profiling of pregnant women is very key. And pre-eclampsia is one of those conditions which will benefit from risk profiling and customized management. So in terms of pre-eclampsia, this is preeclampsia prevention, and there is a recommendation that we should give calcium and also give aspirin to women. But the main question is, how do we identify these women? There is an emphasis on trying to identify the at-risk group, but our method of identifying the at-risk group at the moment is still stuck to the history. As you can see here, that give prophylactic aspirin to all pregnant women with high risk factors for preeclampsia, especially those with previous history of severe preeclampsia or eclampsia associated with IUGR or IUD. But we all know that preeclampsia, the percentage of preeclampsia of women with preeclampsia is more in women who have never had preeclampsia before. So that if we use the screening algorithm, we'll find ourselves in a situation whereby we are missing women who are going to develop preeclampsia and we'll do nothing to them, but they'll come to us with the disease. To just refresh you on the pathophysiology, there are two pathophysiological pathways of preeclampsia which are not being suggested. Before, we all learned at school that preeclampsia was a disease that would follow just a pathway whereby there was a failure of remodeling of the spiral arteries, and this failure of the remodeling of the spiral arteries will lead to underperfusion of the placenta, leading to placenta hypoxia. And when the placenta is hypoxic, there's going to be endothelial damage or dysfunction, which will release a lot of endothelial factors that will cause the preeclampsia that we know, where the mother will have hypertension, proteinuria, and sometimes fits and so forth. And this normally would lead to the clinical disease in the second stage, in the second half of pregnancy. So what do we now know, the updated theory to say how does preeclampsia come about? People believe that on top of everything, we have the maternal factors, which include genetic, behavioral, immunological, and environmental. And these maternal factors will lead into two possible pathways. One is the extrinsic, which is the placenta dysfunction, which is as a result of the poor remodeling of the spiral arteries. And this is believed to lead to oxidative stress in the endothelial reticulum and oxidative stress, which will lead to IUGR because the baby is not going to get what it needs and it will not grow. The other pathway, which is thought to be intrinsic, with this pathway, there is a belief that sometimes some placentas outgrow the uterine capacity, and hence they will still be underperfused because of their large size, because they have outgrown the uterine capacity. And this pathway normally does not lead to IUGR, but what it does is that because of the underperfusion of the placenta, the syncytial trophoblasts undergo stress. And when the syncytial trophoblasts are stressed due to hypoxia, they release placenta factors into maternal circulation, and these are the placenta factors that are released into the maternal circulation from the hypoxia-induced factor 1 alpha, the syncytial trophoblast microparticles, and the oxidative stress that happen, and also the pro and anti-angiogenic factors released and their receptors. I'll be coming to these just now. This will lead to the maternal clinical signs. One of the pathways, if it occurs late, then we are going to see late onset placenta, late onset pre-eclampsia. If it occurs early, we may see early onset pre-eclampsia. This pathway does not necessarily give us an IUG or a baby. The baby may normally grow. This is the picture we commonly see, because late onset pre-eclampsia is the most commonest pre-eclampsia compared to the early onset, which makes up about a third, the early onset disease. So these are the suggested pathways, but all these pathways lead to the production of pro and angiogenic factors, which I will just highlight now. These are some of the pro and angiogenic factors that come as a result of oxidative stress. So if there is oxidative stress at the level of the placenta, we are going to end up with the release of S-FLT1. S-FLT1 is the abbreviation for soluble FMS, like tyrosine kinase 1. The S-FLT1 is an anti-angiogenic marker. This also stress impacts the production of PLGF. The PLGF is an pro-angiogenic marker. So PLGF favors good vascular formation, while S-FLT1 suppresses good vascular formation. So this therefore follows that in women who end up developing preeclampsia, the S-FLT1 is going to be increased while the PLGF is going to be depressed. In normal situations, the PLGF, which is a pro-angiogenic marker, is increased while the S-FLT1, which is an anti-angiogenic marker, is less, is not increased in the normal cases. So we are going to see this shift in pre-eclampsia conditions, where we have an increased S-FLT1 and a decreased PLGF. So that if we do the S-FLT-PLGF ratio, it is going to be elevated in women who are going to develop preeclampsia or women who have preeclampsia. So these markers can be used both as for prediction and also for diagnosis. We can use the PLGF to predict that the woman is going to develop preeclampsia within a certain window period, or we can also use them to diagnose for women who come with symptoms of preeclampsia, like women who come with elevated blood pressure, probably do analysis, there's nothing. If you do PLGF and S-FLT and they're above a certain level, you can clinch and say, this woman has got preeclampsia, and you need to manage them as such. This just further expand really what happens. You can see the reduction in the S-FLT. You can see an increase in the S-FLT1 here compared to here, where we have a good balance of PLGF and S-FLT. You can see the ratio is imbalanced towards the S-FLT1, and this less here is more balanced towards PLGF in women who are normal, with normal pregnancy. Right, so we have understood the preeclampsia condition. Now, coming to the screening for preeclampsia, I've already told you that we are screening nationally with the history. We are mainly using history to say they had preeclampsia before and so forth and so on. But that method of screening on its own, unfortunately, is a low detection rate of around between 30 to 40, as you will see. But the FMF recommends that we should screen for preeclampsia using what is called Bayes theorem, which combines the priori risk from the maternal history or maternal characteristic and medical history with the results of biophysical and the biochemical measurement made at different times during pregnancy. The assumption is that all women would develop preeclampsia if their pregnancy is allowed to go up to 60 weeks. But the time at which preeclampsia sets in is a result of competition between the maternal factors or the screening between the different screening components and the delivery date. Women who are considered to have high risk, they have competing factors within them that cause them to develop preeclampsia before they can deliver. While women who are low risk, they do not have enough competitive factors, which I will highlight just now, so that they deliver before they could develop preeclampsia. So the screening model works more on a competing risk kind of model, whereby factors compete with each other to cause preeclampsia to develop for delivery. So what are these factors that compete with each other? These are the factors that compete with each other. We have the maternal characteristics here, which vary from the woman's age, the woman's height. Height sort of competes against preeclampsia, while the woman's age, 5 years, above 35 years, competes for preeclampsia. Weight of the woman every 10 kg gained competes for preeclampsia, and the race, if you are black, it does compete for preeclampsia, and also South Asian in vitro fertilization, chronic hypertension competes in waste, and diabetes mellitus, systemic lupus erythematosus, family history of preeclampsia, paras without preeclampsia. If you have had a baby and no preeclampsia, it competes against. Well, if you had preeclampsia before, it competes for preeclampsia. So it is these maternal characteristics that have to be imputed into the model. In addition, we have to put the woman's mean arterial pressure. The mean arterial pressure, we measure blood pressure in both arms with the woman seated with the arm at the level of the machine, where the machine is rested on a table, sorry, with the heart at the level of the machine, not the arm, and with the woman having rested for 5 minutes. Then we take the blood pressures in both arms simultaneously. How do we get the map? But the map is 1/3 of 2/3 of systolic plus 1/3 of diastolic. Then you get the map, the mean arterial pressure. And it is the mean arterial pressure that has been shown to be more beneficial when you are screening for preeclampsia than using the blood pressure readings. So we have to calculate the map. Then in addition, we have to do the uterinatal Dopplers. The uterinatal Dopplers, they are again calculated into moms. Then we have to include the S-fleet1, the POGF, and the S-fleet1. I've already described what S-fleet and the POGF are. So we'll see how these biochemical markers work in the screening model for preeclampsia. These are the papers that talk about all these tests for your reading at your own time. So if we are to screen at different gestational ages, let's take, for example, we are screening at 11 to 13 weeks using the various screening models here. If you just use the maternal factors, the ones listed, they're not the ones who are using. The ones who are using have a very much lower detection rate. If we just use the ones which I mentioned just before, this is the detection rate for preeclampsia to develop it 34 weeks, less than 34 weeks. If we screen at 11 to 13 weeks, then if you do include MAP, mean arterial pressure, the detection rate, that is maternal factors plus MAP, the detection rate becomes 72%. And it improves, you see, if you include uterinatal Dopplers, up to 96%. And if we include POGF, if we do MAP and POGF, it's 94%. If you do uterinatal PI and POGF, 94%. If we include S-fleet1, it comes to 100%. Now, here's the trick. POGF costs about $60 US. Together with S-fleet1 costs about $130 US. But preeclampsia has to be screened for. If you are working in a center where you are able to do uterinatal PI, you can still probably achieve the same detection rate you will get with PLGF and MAP here. They are almost the same. And you may not need for the women to suffer the PLGF cost. But if you are working in a center where you cannot do uterine PI, it is better that you do PLGF. Because at the end of the day, sending the woman for uterine PI, it costs probably the same cost as doing a PLGF. Because ultrasound scan will cost you 60, with Dopplers will cost you probably more than $60. So it is better for those who aren't able to do uterine PI. The best alternative is to do the woman's blood pressures and then do PLGF. However, we want to aim higher. So in our algorithm, first trimester, for women who can afford, or those on medical aid, because this test can also be done on medical aid. That's the reassurance. So for those who can afford, it is better we just offer them everything, including PLGF and split one, so that we can achieve the detection rate of almost 100% for early onset preeclampsia, because early onset preeclampsia is the enemy here, or in terms of poor outcomes. So for preeclampsia below 37 weeks, you can see that the detection rate goes down a little bit, but it's still very good. And for preeclampsia before after 37 weeks, it doesn't work very well because it's almost missing more than half of them. However, for women who have been screened low risk, they can still be subjected to second trimester screening with almost an equivalent detection rate for early onset preeclampsia. This is the reassurance. This is where preeclampsia is probably different to the Aneuploidy screening. Because the Aneuploidy screening, if you miss the combined test, the other alternative besides NIPT will give you a less detection rate. But for preeclampsia, the detection rate is the same. So women can still benefit. The only unfortunate part is that they will have missed the opportunity for aspirin. And they have to be given calcium. But you know, aspirin has been proven to work in terms of preventing the early onset preeclampsia. So this is the downside of it, that these women are going to miss aspirin, but they will still benefit from calcium and fetal surveillance and maternal, from both maternal and fetal surveillance for early detection of the disease. The rates, you can see that is the same in terms of detecting preeclampsia below 37 weeks if you screen at 22 weeks. What about if you screen for at 30 to 34 weeks to try and detect preeclampsia that happens before 37 weeks? The detection rate is still quite admirable if we use the biochemical markers here. If we don't use the biochemical markers, it's not that good. So you can see that the value of biochemical markers becomes more after 24 weeks. The value of biochemical markers really become more and more important when it comes to screening for preeclampsia later on. So preeclampsia can still be screened for women who comes to you at 30 weeks. That's the message. You have these women who may do not have any history of what has been happening to them. They just come to you and then third trimester. Remember, you can still screen them for preeclampsia using the same algorithm. You can choose to do PLGF S/1 ratio. You will see as I continue my presentation. Then for those who come at 35 to 37 weeks, if you want to pick up preeclampsia after 37 weeks, it's still an admirable detection rate. But it is much improved if you do the PLGF and S/1. Doing uterinatal Doppler doesn't increase much the detection rate. As you can see, that the value of uterinatal Dopplers at 35, 37 weeks in terms of picking up preeclampsia is not as good as it is earlier on. Even at 30 to 34 weeks, it doesn't change. As you can see that those who do MAP and those who do uterinatal PI, there's no difference. But the value is appreciable when you do it 11 to 13 weeks and 20 to 24 weeks. However, this is not a call to say don't do uterinatal Doppler at 35 to 37. Remember, we are talking of screening here, but in terms of diagnosis, we may need these values to diagnose babies who are growing well and want to figure out what's going on. Obviously, if the uterinatal Dopplers are abnormal, it will allow us to make sense as to why the baby is small, because we'll be thinking it's a placenta disease. But we are talking in the context of screening to say we're going to use uterinatal Dopplers. 35, they do not improve from what MAP is given you. Then what happened to those who screen? The high-risk group, they need aspirin in first trimester. The low-risk group, they are not yet discharged. They have to be reassessed in the 22 week scan. If they screen high risk, then they have to be offered calcium and fetal surveillance, fetal and maternal surveillance. What about those who are screened at the 22 week scan? This is what I've just mentioned, that for the high risk, in our context, we give calcium here. And then they are monitored. Then we risk reassess at 32 weeks. High risk, we continue the monitoring all the way to 36 weeks. Then those who have an intermediate risk, intermediate, that means 1 in 100 to 1 in 500. That's the intermediate risk at 20 weeks. They will still be in their risk assessed at 32 weeks. And again, risk assessed at the 36 week scan. The low risk will leave them alone and we'll see them at the 36 week scan. Then at the 36 week scan, if the woman is high risk, they need close monitoring. Then we'll assess at 40 weeks if they have not yet delivered, so that we can optimize delivery. The intermediate risk, again, 40 weeks. The low risk, will leave them alone so that they can wait for delivery. Right. In terms of the utility for the S-FLIT1 and POGF, what are the cutoffs? Now that we are saying we are doing S-FLIT POGF ratio, how do we interpret this result? So for the S-FLIT FG1 ratio, in terms of diagnosing preeclampsia, like we say that these biochemical markers, they are also diagnostic tools and they are also prediction tools. So between 20 to 33 plus 6 weeks, these are the cutoff. There is no role for S-FLIT1 POGF ratio in first trimester. The best test is the combined screening model, the FMF model for first trimester screening. But for second trimester screening, we can bring in the POGF S-FLIT1 in terms of diagnosis here. The rule out, if it is 33 and below, you have ruled out. If it is greater than 85 and above, then the woman has preeclampsia, if the woman is good signs. Then in terms of diagnosing preeclampsia, 34 weeks up to the time of birth, these are the cutoff 33, and the 110 is the cutoff for those above 34 weeks, that they have preeclampsia. Then for short-term prediction or preeclampsia, between 24 and 36 plus 6, we can rule out preeclampsia for 1 week if it is 38 or less. We can rule in preeclampsia within 4 weeks if it is above 38. That is for 24 to 36. So this is the utility to say, how are we going to be using the S-FLIT1 POGF ratio? This is how we are going to use it. This will apply to women who come late to us. Women who have failed to screen in second trimester, the woman just comes. Probably the baby is not growing all day, is the FGR. I want to know, is preeclampsia going to happen here? This is the test to do. S-FLIT1 POGF ratio is what we have to do so that we can properly risk profile. Then what about POGF alone? Can it be done alone? Yes, of course, you can do POGF alone. So if we use a cutoff of 100, less than 100 in the prediction of preeclampsia requiring delivery within 14 days. These are the detection rate here, the sensitivity. You can see it can get to 96, 94.9. Of course, these are the positive predictive value, which you also have to be aware of. Then the negative predictive value is very high. So that means if it is normal, you are more likely to be okay. If it tells you that the woman is highly unlikely to have preeclampsia, you are more likely to be okay because of the very high negative predictive value, which is quite reassuring for women with preeclampsia, or you suspect you have preeclampsia. Then what about the performance for POGF on its own in terms of women developing preeclampsia within 14 days as a prediction tool? It depends on what you are using, because there are various PLGFs. With the Dofi Express, we are hoping that our partner will tell us what it is. Then with the Quildotridge and the Roche Elysis, this is for the S-fluid PLGF. So the ruling in threshold varies. 50 picograms for Dofi Express and Quildotridge is less than 12 picograms. These are the ruling, and these are the sensitivity here. So on its own, you can see that the sensitivity is not that great. Even the PLGF is about 65%. So using the biochemical markers on its own outside the MOT variables will not pick you a lot of preeclampsia women as compared to using the MOT variables alone. Then in terms of yeah, I think this is the same table which I've just presented, but just to show you again the same table, right? And just to compare here, so that you can see where PLGF alone is, so that when you are using it alone, you should know that the detection rate is way less as compared to using it in a formula. So it is better to use it in a formula, as you can see from the detection rate here, that the detection rate is much better if we use in a formula compared to when it is used alone. Right. Then, what is the screening strategy in pregnancy from trimester, from 0 gestation age all the way to 40 weeks? When women come in the first trimester, it is better we offer them the FMF screening algorithm for preeclampsia, where we combine everything else. We will have a high detection rate here, so that we can pick up the high risk and put them on aspirin, and then the low risk, we can leave them alone and follow them up at the 22 weeks. When they come for second trimester, again, the FMF algorithm is better. The combined algorithm, where you do the uterinatal Dopplers and include the PLGF in the screening algorithm, it's better. Then in third trimester, if women come to us in third trimester, let's start with those we are suspecting to have preeclampsia after 24 weeks. It is better to do the S-FLT1 PLGF. If it is less than 38, we know that they are likely to progress within 1 week. If it is greater than 38, progress within 4 weeks. They are unlikely to progress within 1 week. But if greater than 38, likely to progress within 1 week, and these women, you need to really follow them very closely. If they are low risk, based on the first and second trimester, you rather risk assess them at 36 weeks, either by the 35 to 37 weeks, FMF combined algorithm, or you can do S-FLT1 and PLGF and calculate the ratio. If following S-FLT1 and PLGF measured at 24 to 28 weeks, if the S-FLT1 and PLGF ratio is less than 38, then standard surveillance is recommended because they are unlikely to develop. But if it is between 38 and 85, increase surveillance. Then if it is greater than 85, then a high level of surveillance is required. Then in cases where you are following second trimester FMF combined algorithm, if they are low risk, standard surveillance and reassessment at 35 to 37 weeks recommended. And if it is intermediate risk, reassessment of risk at 30 to 34 weeks is recommended. If the risk is high, then this is a high level of surveillance with weekly BP assessment of BP. We recommend home monitoring and weekly proteinuria. Then between 24 to 31 weeks, and we reassess at the 32 weeks appointment. So this is what we recommend in the application of the S-FLT PLGF. Their role, they should fit in the FMF algorithm in the first and second trimester. Then in third trimester, they can do just biochemical markers to either try to diagnose preeclampsia or to try to predict preeclampsia in women who you may consider at risk of preeclampsia. Then this is essential information that we are required to complete when we want to do the screening algorithm. We should make sure we put in all these details, both for preeclampsia and aneuploidy screening in the request form for the laboratory, so that the laboratory can in turn calculate the risk. And this is how the results will appear, both for aneuploidy and also for preeclampsia. And these are if the risk cutoff, if the results are higher than the risk cutoff, then you need to take the necessary action as described. Thank you for listening. I will leave the room for questions. I think our time is up, but if you have one or two questions, I'm more than willing to ask. I'm not sure I still have people. I still have people. So any questions we may have on the top? So this is how we will be moving forward in terms of screening for preeclampsia, both in the public and the private sector. We are aware that some patients won't be able to afford the split-1 and POGF, but for those who can afford, we'll give them the benefit of doing the test. Those who can't afford, that means we'll still offer them a very test, include uterinatal Dopplers. So no one will be left behind, really. Everyone will be screened. I assume there are no questions. If there are no questions, I think I'll end here. The presentation will be available on our I was muted. So I was saying in preeclampsia, the anti-angiogenic factors, which are split-1, thromboxanes, and so forth, they cause vasoconstriction. So that vasoconstriction causes the blood pressure to go high. That's the relationship which is there between preeclampsia and high blood pressure. So preeclampsia on its own favors vasoconstriction because of the angiogenic markers, anti-angiogenic markers, which are released from oxidative stress at the level of the syncytial trophoblasts and so forth. Right. I think I'll stop here. Thank you so much. I think I did the opportunity to gauge how much it takes to present this talk for tonight. Otherwise, all the best and